Yeah, can you hear me?
Yes, I can hear you now. Can you hear me?
I can.
I can't hear Dr. Nangasima right now.
Oh,
She's
I'm
still
sorry. I'm sorry. I needed to unmute myself.
Okay.
Okay, thank you so much, and welcome everybody. Hello, Lillian, as well, and we're just waiting for Dr. Ngwenya to join us. But in the interim, I'm sure she'll be with us shortly, as she's confirmed. I would like to welcome the panelists to this roundtable where we're talking about the future of medicine, but just not only the future of medicine as designed by women, which I think is an apt topic for this gather. The purpose of this conversation is not really about today's work, and I think it's important for me to frame as the moderator where the focus is going to be. Of course, visibility, inclusion, representation, those are all very important conversations that matter, and they matter today. But what we are going to focus on is understanding all of those issues. What could the future look like? So this is really an opportunity for us to imagine or even reimagine the design of medicine. And so this conversation, hopefully time permitting, we'll try and move across different aspects, which include values, careers, policy, technology, and leadership. I know all these women personally. I've interacted with all of you, so I know that we have quite a broad range of views, and so it's important to say that the purpose is not to gain consensus. It's just to name what is currently working or not working for us as women in medicine, and then imagine what could be built differently. So before we begin, I am going to take the opportunity to introduce the panelists that are here with us today. And I'm going to start with Dr. Maisha Claiborne, who's an integrative physician. She's a thought leader. She's also an NLP trainer who helps individuals and organizations to understand how trauma shapes the brain, behavior, and communication. She's also the founder of Mind Remapping Company, and she supports leaders and systems to become genuinely trauma informed in how they relate, how they lead, and how they perform. The second panelist is Dr. Ali and Aliobe, known as Dr. Ali Eri Emulo. She is a board certified primary care physician, a speaker, an anti-bullying advocate who's based in Little Rock, Arkansas, in the United States. And her focus is on physician mental and emotional well-being. She is a strong advocate for the medical profession. She founded Physicians Keeper to promote respectful, psychologically safe cultures in medical education. And the final guest is Lillian Wehangana. Lillian is a medical student at the University of Zambia and an emerging leader in the youth and health advocacy. And of course, if we are talking about the future, we have to have the people who are going to be in the future. She's the founder of Youth Link Zambia, and she's also the Secretary of Health for the University of Zambia Medical Students Association. And her work spans mentoring, health education, gender empowerment through active volunteer roles, such as with Go Power Platform or with the YWCA. So welcome to the panelists. I'm sure we're going to have a very good conversation, given that we are also going to be looking at different points of the system, from training to practice, leadership, and innovation. But before we do that, I'd like us to maybe anchor our conversation in some principles. And so I guess the first question that we'd want to ask, and I wonder if I can move this forward. The first question that I would want to ask is really around values as an organization. So before we talk about solutions, before we talk about structures, if we were to take a step back and identify some principles. So maybe I'll start with Dr. Maisha. When you imagine a healthcare system that truly works for women, what are the values that you believe are non-negotiable that will be at its core?
Thank you. I think that when we look at the future as designed by women, we are looking at values like collaboration and community. We're looking, of course, at integrity, but like this concept of shared leadership and collaboration and community, I think are strong things that we're sort of missing in today's world.
Absolutely. I think that's certainly the way that we live as women. Collaboration is, when we talk about a village,
Mhm.
we definitely collaboration and relational centered people. Lillian, I wonder if you have a view about that as well. What are the values as an early career or as a medical student from your vantage point that would sit in this redesigned medicine?
I hope I'm audible enough.
Yes.
Thank you so much for the opportunity, and I'm glad to be here with everyone. Yeah, so for me, I feel like the principles that we really have to put in line as women redesign in medicine is not theory being the main thing that's governing us, but us women having to redesign medicine from real life experiences. Yeah, I feel like that's the main thing for me.
Absolutely. Thank you for that, Lillian. It's really about it being rooted in the realities of medicine. And as we know, it's not a challenge. It is what it is. Like in many professions, we know that medicine is male coded, and maybe it is structured in a way that has not always included the realities of women. And I think we will definitely get back We'll get into that conversation later in our conversation. Dr. Ali, for you, I know in the work that you do, it's all about values, or very much rooted in values. What are the values that you believe future healthcare system um, should be rooted in, that would include or be mindful of women?
Thank you, Dr. Onasimo. I'm glad to be part of this today. For me, I would look at it, just from a patient standpoint and also from a physician standpoint, things like dignity when it comes to women's health, where, women are believed, with their responses initially and not dismissed as you're being emotional about this or you're overreacting about this, where our feelings, our symptoms do matter and are taking, in with the same severity as if it were a man. And also safety, very important as part of the values for women in the workforce and also for patients. From a personal standpoint, I know the struggles that I had, from a training standpoint, and part of those I felt would not have happened if I were a man, right? There'd be certain things that um, I would have been more vocal about, and I did not want to respond in a certain way that it felt, oh well, it's just because you're being emotional about this, and so preserving my dignity would have been being taking the weight of what I said as serious as if it were a man who said it. And I've seen, other physicians, even as a popular physician coach that I know of who was an MD, who presented to the hospital with severe symptoms of sepsis and was taught of being anxious. That was the initial dismissal, that she was in an anxiety state. And so that robs you of your dignity when your symptoms are not taught as of severe, or they're put it to the side as this was just an emotional response. And so I see a system where dignity and safety are at the forefront of the values in a designed by women.
Mm-hmm. Thank you so much for that, Dr. Ali. I think that was really well articulated. When we think about some of the systems really having the skill set to understand male coded articulations of frustration, and as you said, perhaps using a different way of ensuring that the way women might express themselves and articulate their frustrations would be different. So we do need a system that is sensitized to both men and women. Thank you for that. So as we think about these values, and I'm going to stay with you, Dr. Ali, because I know you also are doing some academic work, but the other colleagues will also weigh in. When we think about these values, and if these values that we've identified actually guided investment and research priorities, right? What are the areas of women's health that you think would move faster or finally received the attention that it has not received up to now?
Oh, there are a whole there's a whole spectrum of that, but I'll try to narrow it down as the ones we commonly see. So especially when it comes to autoimmune disorders, right, which women represent about 80% of autoimmune in terms of population compared to men. From my experience, those are the um, one of the cases I would say that it takes a long delay in diagnosis or even believing these symptoms. And so, in a system where if we were to advance research and this was led by women, I believe that things like autoimmune disorders, we would have earlier diagnosis, earlier treatment, prompt responses, more serious responses, right, to those complaints. And even when it comes to issues surrounding, pregnancy, menopause, um, PMS, name it, that center around women's health, If research were geared towards that, a lot of symptoms that women deal with, we would have a quicker response time, quicker treatment. Women will show up better to the workforce, knowing that they were heard, they were treated. Patients would feel better knowing that they were heard by their doctor and there's something in place to make sure that their symptoms are not pushed to the side.
Very well said. I know, Dr. Maisha, you've got something to add for sure around that.
Of course, of course, menopause is high, high on the list of things that I think would be advanced in terms of research, because I think that's something that, with a bit of ageism, has been pushed to the side. We're just now, like, really touching the tip of the iceberg with that, but also, really kind of alongside of what Dr. Ali said is like rare diseases. I think rare diseases in women would probably get more attention if we had women leading the research efforts.
Great. Thank you so much for that. Dr. Lillian, I see Dr. Ngwenya has joined us. I know she has some technical issues. But in the meantime, Lillian, if you, I don't know from where you sitting as a medical student, perhaps you might have also had reflections on this and where you think the research priorities might be for women.
All right, thank you so much. So for me, I feel like I'll just add on what the senior doctors have already said. I feel like issues that have to do with mental health with regard to postpartum, postmenopausal, yeah, I feel like those are things that are just overlooked, and I feel like they really affect, or just young girls like us. I think the different hormonal cycles we have to go through affect our moods, and that's not something everyone understands. And yeah, girls just have to numb their feelings here and there, just not to be seen as weak. Yeah.
Mm-hmm.
Yes.
Yeah, wonderful to hear from a different generation of up and coming doctors. Dr. Skululiwe Ngwenya, welcome, and apologies for the technical issues. Just to introduce everybody, Dr. Skululiwe Ngwenya is based in Zimbabwe. She's an experienced medical doctor with a strong interest in digital health, in emerging technologies, and also she's a blogger, and she's fascinated by technologies that enhance the patient experience and passionate about evidence-based clinical care. So welcome, Dr. Ngwenya. Can you hear us? I wonder if you can hear us. Okay. All right. So we missed that. I'm sure they're going to bring her up again. So maybe while we are on the issue of the research priorities, often, as we build evidence, what we want to see is that evidence becoming policy, and policies that are actually shaped by the lived experiences of women. So if we were to translate what we have discussed so far into policy, how do you think that the policy changes, or how do you think health policy changes when women's lived realities are treated as essential data? So, and aligning also with the lived reality. Let me ask Dr. Ali.
So I would lean in the sense of, especially when it comes to reproductive health, right? That's a huge chunk of a woman's life. There are a lot of policies that do not favor women at different stages of their life, especially when it comes to their careers, where sometimes pregnancy is seen as an interruption to a woman's work life, as opposed to seeing it as a gift or a joy. So it's almost, let me give a practical real life scenario. If you're a residency training program and then you get pregnant, it's almost like you're not being considerate of your training, as opposed to this being a thing of joy, then it's almost a thing of dread, where then you have that fear that if I do go in and tell that I'm pregnant, what would that look like for my training? And so it puts then a lot of stress on the pregnant individual, and down the line, it then impacts her career because she has this gap and it says, why did you take off during this so and so time, and gets penalized. So I believe that if we had policies in place based on these experiences that would account for these changes in women's lives, pregnancy, childbearing, knowing that right after 6 weeks, it's probably not enough time for a mother to, stay with her newborn. And there's a lot of anxiety that goes into that, extending those time frames as to when she is comfortable, you know, paid leaves, extended paid leaves, as opposed to having to decide between, you know, if she's a sole caregiver, how can I balance providing for my family, going back to work and living my newborn? So I think that policies would center a lot about women's reproductive health, especially when it comes to the pregnancy part.
Mm-hmm. Welcome back, Dr. Ngwenya. Can you hear us?
I can hear you. I don't know if I'm audible now.
Absolutely perfect. So we're just going to jump straight into it just to give you an opportunity as well to weigh in. I know you're going to hit the ground running. So we're really talking about policy. I'm not sure if you heard the conversation. So we've basically talked about some of the values that we believe would guide the investment and research priorities, the areas of women's health that we think would then be informed by those values. And so we're now really at a point where we're wanting to translate that into policy. And so the question is really, how do you think the health policy changes when women's lived realities are treated as data or are considered?
Thank you for that question. I think for women's health, there's need to have more inclusive involvement of women in the processes of research or testing of technology devices and healthcare products, so that these devices can really help the women that they are targeted for. So I believe that the policies, they also need to consult women at different levels, whether be it care providers, patients, people in the community, and so forth, and really include the voices of everyone. Every woman's voice needs to be heard.
Mm-hmm, mm-hmm. And thank you for that. And I think that's a great segue, maybe to draw Lillian into the conversation as well. When you often talk about women, we're not one monolith, right? And so they are. We don't have one life, one body. And I'm curious, Lillian, from your perspective as a medical student, what are the policies that you think would best reflect young people or that need to be considered in developing health policies?
Okay, thank you so much for that question. I believe there's so many gaps that are there right now, and I feel like how best can I put this? Right now, being a girl in medicine is no longer. Most people will think you're being too ambitious. I feel like now the that myth is going down a bit because we have more women in medicine. But I feel like best believing in us. I feel like as young girls, helping us. I think like having females that have gone before us that can show us the route and tell us that it's possible could help us. I feel like that brings about mentorship for young student physicians. So I feel like issues to do with mentorship, especially for female student physicians, I feel like could go in best for us.
Mm-hmm, mm-hmm. And yes, definitely, we have a lot of life experience amongst us. And so maybe I'm going to throw this question back. And I think Dr. Ellie touched on it, but maybe the rest of the panel is also well positioned to talk on this. Building on what Dr. Ellie mentioned earlier, about medical careers that take into account normal life events like caregiving, like pregnancy, like maternity leave, like menopause. What would what would medical careers look like if those were considered and those parts were or those aspects were just part of professional life rather than what it is at the moment, which is disruptions to one's career trajectory. Dr. Ngwenya, what do you think?
I think life events should be treated as normal events that can happen, whether be it motherhood or fatherhood. It shouldn't mirror what people think is possible for the girl child or for the boy child. I believe that there should be support and flexibility in the workplace where opportunities should not be refused to people because you're likely going to be pregnant, especially if you are young. You think that you're going to be pregnant every 6 months or something like that, but it's not realistic. Whatever choices that you make in your personal life shouldn't affect your career. And I think also as women, we also need to support each other as well and not feel like if someone needs to take a breastfeeding hour or something, they're slacking off work or something like that. We are all women at the end of the day, and we should be our biggest support network.
Mm-hmm. Dr. Maisha, I know that you work with organizations, and so you know firsthand how this plays out in workplaces. Can you weigh in on that issue? What would it look like to have medicine reflect the realities of our lives?
Absolutely. I think that, coming back to centering the values again, if we're embodying those values of community and collaboration, nurture, love, shared leadership, what we're going to see is a difference in how the job shows up in general. We may end up with more job sharing, just to reflect the flexibility of the life that we lead as women. We will likely have more coverage, as Dr. Nguyen, forgive me, Winya said, around these normal life events and how we need to support and cover for one another. And so I think there will be more of an emphasis on community and coverage. And then overall, we see longevity in our careers. So because we have that support, because we would have that potential for job sharing, not all people want to work full time. And so to be able to have that type of collaboration will bring us more capacity to work, to bring our best selves, more career longevity, less burnout, less moral injury. And I think overall for organizations, better retention of top tier physicians and talent.
Mm-hmm. No, thank you for that. Let's look at, I was going to talk about burnout, but let's move forward so that we can talk about the issue of success metrics, and maybe we will introduce burnout as you've already mentioned. And if burnout was important, how might we need to rethink how we measure, what we measure, and also what we reward as success in medicine, compared to now, where it's really about productivity, right? The RVUs, the number of patients that you see. If we were to center women or redesign medicine, what might those success metrics look like? Let's ask Dr. Ali.
So I would lean towards patient experiences and patient outcomes as being the metrics, where I don't have to see 30 patients a day, but and churn out poor quality or quality outcomes. But if the 15 that I see and spend time with, and you're able to measure their health patterns from when they started and where they are now, and you see that their diabetes is better, their depression is better, their high blood pressure is better, they feel like they can be in charge of their health, and you are able to measure those metrics based on not the volume now, but the quality of patients. um, that would be a great measure. Um, the current system, like you said, doesn't favor patient quality. It focuses a lot on patient quantity. How many can you see? How, get those numbers up, but then not take into fact that that time was not enough for the patient to feel like that they heard their doctor, or for the doctor to go down deep into the issue. So this is a non-compliant patient. And then all we're focusing is, well, you're not compliant, but we don't have that time to actually sit and find out that there's some struggles with transportation, there's some struggles with finances, and all we do is just, okay, make sure you take your medication and then prescribe more. And then they come back again in 3 months. You're going to have the same outcome at the next visit that you did because of the time. So you have the numbers, but the quality of patients are still at the same level. So quality, I think, and patient experiences would be the metrics I believe should be used to replace for success.
Mm-hmm. Definitely, maybe less about the productivity and more about outcomes for patients. Dr. Esco, I know you're working in digital health as well, and this might translate a little bit differently. From your perspective in that space, I wonder if you agree with Dr. Ali, but also how would, what are the metrics of success that you think could replace the ones that we have currently that are so focused on productivity?
Thank you. For me, the metrics I agree with what Dr. Ali was saying. I would add that we also need metrics to do with tracking of patients if they have missed visits, missed refills. If there are no shows, we need to know what happened to them. And patients also, they get lots of times. There are many things that happen within the 3 months in between the visits. Sometimes they go and find that the insurance is not paying for their medication, and they can't get a slot to see the doctor again. So that means they're going to wait for 3 months before they come back, unless they get admitted, which is something that we would definitely wouldn't want to happen. So there are lots of things that digital health and AI and technologies that are there these days could help with, especially with the tracking, even monitoring the diabetes over time. Sometimes in some clinics, patients are seen by different providers every time they go for a visit, especially in public hospitals, which makes continuity of care something that in the current state, leaving a lot to be desired. But if things are being presented digitally in a way that is helpful for the patient and the provider, it means that the devices in front of us are not being obstacles of care, but are actually helping us improve the outcomes, improve the productivity and efficiency of the clinics in our hospitals and facilities.
Mm-hmm. And staying with you then on the digital and the AI, I think obviously if we're talking about the future, we have to acknowledge those changes, right? Where we are going to see a bigger role for AI and technology and digital systems. What is the role of those tools in enhancing the experience for women in medicine?
For me, I think the best tool, probably many women have experienced the period tracker app or the pregnancy tracker app. I feel that if every aspect of medicine is as good as those health tracker apps, it means that these tools are actually used for the purpose that they need to be used. The tools, they also need to be efficient for the doctor, for the specialist, in ensuring that there's continuity of care and no one is left guessing why this patient is on warfarin or why this drug was stopped and things like that. But in the current state, with the paper records and the systems that don't communicate with each other, lots of information, precious information is lost or not communicated well across providers or even with the patients themselves. So there's really lots that is happening now, and there's lots that is going to happen in the future to improve experiences for both care providers and patients. And I'm glad to be part of the movement, and people make experiences much, much better for women across the board.
Mm-hmm. Lillian, I'm not going to assume, but please forgive me for assuming as a young person that probably you're already very much involved in the utilization of technology. So, from your perspective as a medical student, how might AI and digital health and all of those evolve if their primary goal was women centric?
Oh, thank you. So just to add on what Dr. Ngoni and Dr. Ali said, I I feel like having patient modules would really help us in the hospital, because I feel like doctors would have patient information on their phones at their homes, and they have enough time to check through and study everything they have to study on the different patients they'll see the following day. And I feel like that does not only buy them time, but also I feel like it gets them prepared for what they're going to meet when they come to the ward the following day. So I believe like with digital health that's coming up, we could have patient modules, like have a module in hospital for everywhere, every patient's details or the labs they've ever done, what they're taking is being recorded for each patient. Then every doctor has access to that module for each patient. That way, I feel like, because honestly for me, we do have times where they did order for ultrasound, but then you ask the relatives, like, where is the ultrasound? And they have no idea. Then you have to again send them to radio to do it, which is time. And I feel like that's what increases the lines there and whatnot. So I feel like having it online will really buy us time and better patient outcome.
Mm-hmm. Just staying with you, Lillian, by the time one completes medical training, and I think in most countries you're looking at least 10 to 15 years, the world that you when you started and the world that you leave at the end, right, of your medical training is not the same. And I'm wondering how, with the disruptive nature of medicine, what are the roles that you anticipate might change? And what are the new roles you think that healthcare needs right now that don't yet exist, but probably should? Lillian?
As I feel like for my country, I'm going to speak for us. I feel like we don't have so many uh, nurses, as they don't employ as much nurses as we should have in our hospitals. So I believe us employing or having more nurses, especially because they do have a one-to-one relationship with most patients, would really help us. So yeah, I feel like I would wish for us to have maybe moderate amount of doctors, but more nurses, just to allow for patients to really have easy healthcare services near them. I don't know
Mm-hmm.
if I answered the question right.
Yeah. Dr. Ali, I know you are in academic medicine, and this question might have come up for you as well. What are the new roles that you see for the future, if you were to design it as a woman, of course, and also what are the roles that you think are no longer going to exist in the future?
Okay, before I answer that, I'd just like to piggyback on that digital advancement when it comes to AI, because I'm in that field now where we are begging for AI scribes where I work, and we're asking, hey, please give it to us. And the reason why I feel it'd be so helpful for us would be, we enter a patient's room and all we're doing, we're on this, like we're typing, we're trying to meet up with those demands. We have those notes we're supposed to close. They give us deadlines. These notes need to be closed in 3 days. You need to submit this. And for me, what that would look like is, if I do have a scribe that takes the necessary information when I'm in the room, I can focus on the patient. Like, I don't have to worry that, oh, did I miss this? Did I miss that? Like, they have my undivided attention. And so they don't leave there feeling like the doctor was on the screen the whole time and they listen to me. And I always tell them, look, I'm not ignoring you. I'm just trying to make sure everything you say is documented. So if we do have those that come in, AI scribes, they would save the physician time, because a big thing with us is burnout, right? And so when half of your work is already done before you leave the room, then you can close up those notes. You can go home. You can spend that time with your family. And so your patients benefit from that. You're not as stressed out. Then you get home and your family can also enjoy you because you're not, half of you is not trying to meet up with the demands of work. So I believe that once we advance in that, that would solve a whole lot of problems. Now, regarding the roles that I believe should come in play when it comes to the future of healthcare, coaching is a big thing. You know, coaching is a very big thing that I believe should be afforded to every, physician, everyone who's going into the medical space. In the past, it wasn't coaching wasn't well embraced because people did not understand the dynamics of it. But now we see the roles they play, even for physicians, right? Mental health coaching. Um, now there's a whole sphere of coaching. There even charting coaching. You're struggling with your charts. There's someone who can help you sort that out. And so mental health, I believe, plays a huge role in physician lives. And I believe that if coaching was something that is embraced completely, um, every organization would give physicians access to coaching, be it business, even business coaching. You're a physician and you're so, medicine is all you know, but then you want to know, okay, if I want to deliver the best care to my patients, I know I have to know a bit about business so that whatever I'm doing, I can multiply it because that multiplication comes with finances. But then you have no clue what to do differently. So even business coaches should be a thing for organizations to think. We have this physician who wants to grow in this area. Let's make sure this is available. So I believe that coaching should take a very big role in the future of healthcare, and organizations should look for how they can fund these for physicians who are in those spaces.
Right. And Dr. Maisha, you knew I was coming to you. Definitely as a coach, but as somebody who really understands the career development space and where new roles could potentially exist in the future that we might not have today, that would speak really to the challenges that we have in healthcare. How do you want to weigh in on that?
Well, what I want to say is that when we talk about metrics, and I'm going to come right back to this, one of the things that is often left out is the stories of the community. And stories are the stories and can lead to the data that we need to create those outcomes. And so what I'm thinking in terms of like what might exist that doesn't exist today is a community liaison. Maybe that community, maybe there are community liaisons that are healthcare professionals, physicians, but they're also the community liaisons that are from the community. And so then what happens is that you start to gather the stories of what's going on in the community and begin to measure community outcomes and measure those stories and measure the trends and the progress. And that's a different way to think about metrics. I think also just on the physician side, to bring it back a little bit physician centric, one of the things that technology can do is similar to what Dr. Ali said, is oftentimes when we're finished with a patient visit, we like to give a summary. And oftentimes we spend a lot of mental energy trying to translate that summary into what would be understandable by the patient. So I wonder if one of the evolutions of AI would be to translate for us from what our summary is to what the patient would understand based on their language, environments, level of understanding, and I think so there could be a role around creating technology or AI technology in that domain as well.
Mm-hmm. Thank you for that. So we're almost at the end, but I do want to squeeze this question in about the future generation of girls that are coming up. As we know, medicine nowadays really is represented, is no longer the profession that we probably found, which had less women than men. I think for the last 5 years now, we've seen more and more young girls entering the profession. So the question is really, if we were to look beyond the institutions, what shifts when future generations of girls grow up seeing themselves everywhere in medicine? We still know that there are some male-coded specialties, for example. But what would shift if they were able to see themselves everywhere? Let me start with Dr. Lillian, because I know you are already in that space.
I thank you so much. I feel like it wouldn't be so hard for us to come out of our shells. Yeah, I feel like we would boldly come out and do everything because the world already believes we can be anything. Yeah, I think that's everything.
Thank you for that. Dr. Ngwenya?
Girls would have big dreams and big goals, like straddling across academia or business, having your own clinic, doing great things out there. I think we need lots of examples like that, especially in the African setup. So I really look forward to that in the future.
Mm-hmm. So we are at the end of our session and we just have a few minutes remaining. And I wonder, just as a wrap up, if I could have just really 30 seconds from each of you about your dream about the future of medicine as designed by women. Let's start with Dr. Maisha.
Thank you so much. I envision a time when we no longer say the first woman in, the first woman in this specialty, the first woman in this leadership position, the first woman president of a hospital. I envision where when there are so many girls seeing us do the things that we do, that we will that will cease to exist.
Mm-hmm. Dr. Ali?
Thank you so much for this opportunity. As I wrap up, I would like to say my vision for this would be where women are not just limited to one space, where you can have a good family life, you can have an excellent career life, where you don't have to choose between how many kids do I have versus serious do I want people to take me in my career, or without putting a stop. It's like I can thrive both at home and I can thrive both in the workforce. So you bring your best selves to every sphere that you dominate.
Mm-hmm. Lovely. Lillian?
Thank you so much. So I believe and wish that the future medicine will be not the rough medicine we entered into. I wish medicine could be a better place for females. A dream they'll achieve knowing very well that they'll find pride in it, work fully without knowing it would take a lot from them because treatment is really a calling. So I hope and wish that this is going to be a safe place and a great place for all the girls out there that are coming right now and after us. Yeah, thank you.
Well said. Thank you, Lillian. Dr. Ngwenya?
Uh, Thank you. I think medicine should be flexible, have flexible healthcare delivery options for both care providers and patients. I should be able to do whatever I want as a woman and still be able to fit in all the needs, medical, social, and be able to do it all.
Wow, wonderful. Thank you so much. So I really want to thank Dr. Maisha, Dr. Ali, I call her Dr. Lillian. I know she's still a medical student, but I call her Dr. Lillian, and Dr. Sko, for your honesty, for your rigor, and the seriousness that you also brought into this conversation. So as we close, I just really wanted to reflect on what we've done here. Of course, the aim was not to solve the problems of medicine today. Ours was just to name some of the important things, some of the many pressures that we face as women, and that we experience in medicine. And what I think came out of this conversation is that these are not personal failures. This conversation is not going to stay only in this room, I believe. I think already all of you are doing so much work already in your own spaces, and hopefully the mindfulness that comes from these conversations means that we're going to continue to impact how we lead as women, into how policies are written, how structures are designed, medical training, and how our careers are also structured. So your contribution has really assured me that the future of medicine is in good hands, and certainly the work will continue beyond this evening. So thank you very much for all of this. Thank you.
Thank you very much. We appreciate it.
Thank you.
Thank you.